Well, let's go back in history again. All of my patients with HIV early on, we treated them with prophylactic antibiotics, whether it was Bactrim or something.
Sure.
Because we knew somewhere down the line they were going to catch something bad.
Right.
But now you're telling me that you can control the HIV really well. So where do we stand, A, on prophylaxis? What do you use as an indicator for the necessity for it? Is it the viral count? Is it the CD4 count? Where do you go with that?
It's basically the CD4 count.
Okay.
But I think we use far less prophylaxis than we used to.
Okay.
So I think the only disease I prophylax is pneumocystis in a naive patient.
Okay.
But it's tough to teach the residents that. It's
know.
so hard.
Why is it so hard?
They love azithromycin weekly.
Right. And it's
So
like,
there's-
wait, no,
there's
don't
this-
mess up their lives. Get them on antiretroviral therapy, you know, and it's
It's a
an ingrained
holdover.
concept.
It's just a holdover.
right.
There's, people look at these ancient recommendations that haven't really been effectively updated, I think.
They can't be. They get the studies that were done to, for example, Mycobacterium avium
No, but
complex.
they can be. They can be updated.
The
They
study would
can
have to
be-
be gigantic, and who's going to fund it? And
but-
so,
Well, but I think that
focus
there's-
The
in.
point is that the
What do you-
guidelines
there's-
are changing. The guidelines do say, for example, for MAI prophylaxis, that start them on antiretroviral therapy, and you don't necessarily need to start.
that's what one set of guidelines
One set of
says, yeah.
guidelines.
Okay, well, that takes care of Mycobacterium avium.
But not
in one
everybody is taking care of patients that you tell them to start their antiretrovirals and they do.
Right.
In fact, often the people who get admitted to the hospital are not just newly diagnosed. They're the people who leave and don't
Right,
start
sure.
antiretrovirals.
But if those people are not taking their antiretrovirals, they are not going to be taking their MAC prophylaxis. So
I'm getting a headache at the
So it's really HIV therapy, and the important thing for
I'm not going to take
providers
that message back
for
to my house
providers
now.
to understand is that when viral replication is under control, it doesn't matter what the CD4 count is. It can be 50. It can be 10.
Okay.
If the viral load is undetectable, those folks don't need OI
Okay,
prophylaxis.
wait, let me just.
Although Joe is like
That's
wiggling in his
that's
seat.
There are
Joe, let me handle this one
Okay,
just for a
you can
moment.
just have
Because I
it
want
move on,
to
that's
put a nail in it, then I want you to hammer it.
Okay, fine.
Are you telling me that somebody whose CD4 count is low, whose viral count is low, is not at risk for Mycobacterium avium? Go ahead, it's yours.
I think the data are that if people, certainly the risk is dramatically reduced if people are suppressed, even if their CD4 remains low. However, if you look at across a large population, they do have higher risk of opportunistic infections if
Compared
they're
to all comers.
compared to all comers with HIV. So, but I do agree with Ian. It really is probably pneumocystis prophylaxis that I wouldn't shed.
And TB for
Oh,
skin
right,
test
of course,
positive.
that's-
That's
yeah.
a different.
I mean,
that's a separate.
For skin test positive, that is people who've been exposed.
right,
and
yeah,
have been
yeah.
exposed.
Or interferon gamma releases.
So let me see if I can nail it down. If somebody's on effective antiretroviral therapy, virus count is low, CD4 count's okay, would you or would you not, show of hands maybe, prophylax for pneumocystis?
Well, if it's
We're
low,
50-50?
pneumocystis.
Well, between
there's-
100 and 200, I don't prophylax.
Right, I agree.
When you're starting.
No, yeah, or even someone has poor immune recovery, whose
Right.
CD4 is between 100 and 200,
No, I
whose
completely
viral
agree.
load is
Right.
suppressed, I do not give them pneumocystis
And
prophylaxis.
that's consistent with the
That's the
guidelines.
recommendations.
Right.
If their CD4 count is greater than 100 and they're virologically suppressed,
Right.
they don't
Okay.
need prophylaxis.
Let's
But
ask.
it's also important for folks to understand that really the situation that I was mentioning before almost doesn't exist, because when you've got viral replication control, the CD4 count is not going to be 10.
Okay.
And on these new drugs, CD4 counts often rise 100 cells during the first month of therapy.
Okay.
So they rapidly get their CD4 count above a threshold that we've traditionally associated with being at risk for these opportunistic infections.
And just to be clear, again, somebody is on effective, however you want to define that.
Sure.
AR2
Well, no, we know
therapy.
how to define it. Viral load below the limit of detection. That's
Fine.
actually not an argument.
Okay.
That you won't get an argument there.
Viral load below the limit of detection.
Right.
Are you prophylaxing for Mycobacterium avium complex?
No.
Fine.
Okay.
No.
We
period,
got a
no.
definitive answer.
So CDC guidelines still include it, and I was talking with John Brooks, who's one of the guys who runs the CDC guidelines, and he basically says, the data are old that support using the prophylaxis. They're never going to do the study to show that it's not necessary, so we've just left it in there. But that's kind of lazy, because the studies were all done in the early 1990s, And that's not the current era that we're in for ART.
But to clarify, on the other hand, if someone comes in and their CD4 is 50.
I do start pneumocystis prophylaxis.
And you start them on ART. I do give them pneumocystis
Absolutely,
prophylaxis
yeah.
until they get above 100 consistently.
Yes, me too.
Okay, so that's, I think we agree on that.
I agree.